major interest, and in the next half hour, I'm going to really sort of try and talk about universal health coverage and really explain that I think it's as much a political issue as it is technical, as it has anything to do with economics, financing, medicine, service delivery. I'm sure you know this living here in the United States. It is massively political. But rather than avoid that and say, oh gosh, this is political, let's not get involved, I think it's beholden us in the global health community to embrace the politics, celebrate the politics, and do the politics. Not just analyse it, but be prepared to roll our sleeves up and fight for what we believe in. Because otherwise, if we don't, we're just not going to succeed. So, first of all, what is universal health coverage? And I think it is important to try and define it early on because there are misconceptions about what it is. And people sometimes associate universal health coverage with health insurance coverage. If you've got a sort of a card that entitles you to curative services, that is coverage. But you can see in this definition, which is a slightly boiled down version of a standard WHO definition, nothing about insurance there at all. It's really is about all people receiving the quality health services they need. Some pretty important words here, quality, need, without suffering financial hardship. It's an essential element that as people access and use services, that they're not plunged into poverty. And also very important to recognise we're not just talking about curative services. We're talking about a whole range, promotion, prevention, curative, rehabilitative, palliative services, but also public health services as well. Really we've got everything that we associate with the health sector, and even beyond into issues dealing with the social determinants of health. Now, going from that definition, it seems quite a simple definition, but that has profound implications. And, really what UHC is about is equity and fairness. So you can see already we're getting into some sort of pretty political waters here. First of all, it's pretty evident, universal everybody on the planet. It would be the ultimate goal, being covered. And certainly, we're sort of talking about all ages, all ethnic groups, migrants. It really should be everyone. Nobody is left behind. Also, from the definition, we're talking about health services allocated according to need. We're not talking about everyone getting the same quantum of health services. Some people objectively have greater need for health services. Pregnant women and young children, elderly people, people with HIV, they need more services than other people who sensibly may be more healthier at the time. And so therefore they should get them. And we are already talking about very important equitable principles of services allocated according to need. But then thinking about this idea that everybody gets financial protection, and knowing that there's huge ranges in people's income levels, logically what we're talking about therefore is a health system that is financed according to your ability to pay. Richer people pay more than middle class people, and poorer people pay next to nothing, and really destitute people paying nothing at all. And if you combine these sort of elements, really what you're talking about is a health system whereby healthy and wealthy members of society cross-subsidise the sick and the poor. Now, I hate to, that all sounds very simple and straightforward, but this is profoundly important, and it very much has implications for the way that you organise your health financing system. Now, I should say that as Joyce mentioned, it's not all about financing. It's very important, and it is. I won't be dealing in my talk about the specific service delivery elements, but obviously all the health systems need to be working for this to be deliverable. But it is the case that if you get the health financing system wrong, you don't stand a chance. And this, I would say, is the consensus on health financing now, as brilliantly articulated in the World Health Report of 2010, which was called something like Health Systems Financing: A Path to Universal Coverage. And it wasn't spelt out as starkly as this, but if you read it, and having spoken at length to the authors, this is what they meant. Firstly, there's a market-driven health system, people just sort of buying and selling health services as you would restaurant meals and maybe sort of buying cups of coffee, will never ever deliver universal health coverage. And quite simply, it's because the cross-subsidisation won't work. I mean, there might be some. You might be able to persuade wealthy people to sort of donate and help people in a charitable way, but that will never happen at a sufficient scale that you will get the equity that you require. And of course, the poster child for that is the United States. The system that is highly marketized, and with private financing function, with private insurance, spending 17-18% of GDP, it's still about 10% of the population uncovered. So, and you can see that attempt to blow up Obamacare and sort of move even more towards a market system explicitly will take 30 million people straight off, coverage. So what you really need is a system that the state forces healthy, wealthy people to cross-subsidise the sick and the poor, compels them to. And in a nutshell, therefore, what you're talking about is some type of public health financing system. It doesn't necessarily have to be the case that the public sector runs the programme, runs the schemes. I mean, you can contract private providers to do that, as happens in Switzerland and Singapore and Holland. But the state must govern it, set the rules, and be involved in all the main financing functions in terms of raising the revenues, raising the funds, saying to the wealthy, you must pay so much through your taxes or whatever mechanisms you used, to create a great big pool of financing and determining the governance arrangements for that. But also saying, now that we've got this big pot of money to cover the population, how are we going to allocate that? Sort of where are the different needs? Should we be spending more in poorer districts? Should we be spending more on mental health services? The purchasing function. Now, switching from a system whereby the healthy and wealthy can sort of basically join insurance schemes that cover themselves and their families, and they're not really subsidising the sick and the poor much, to a much more egalitarian system based on need, is inherently political. And because, not surprisingly, the wealthy won't want to do this. All these vested interest groups that actually prefer a more fragmented system whereby there is sort of differential access to services depending on your ability to pay. Again, you don't need me to tell you this, that this move towards universal health coverage is massively political. And it's all really about replacing private voluntary financing with compulsory public financing. And these are some graphs that I think initially Joe Hudson at WHO started to do, but I think really illustrate what we're trying to do, because here you can see you've got sort of countries that we sort of regard as UHC success stories. New Zealand, Japan, Australia, Thailand, with relatively high levels of public spending as a share of GDP. And that's had the effect of reducing the need for people to pay out of their own pockets. So on the y-axis here, we've got share of total health expenditure taken up by out-of-pocket expenditure. And the whole idea is you get away from a system that people are having to dip into their pockets to buy services in the market. So the WHO really recommends that, at a level of out-of-pocket expenditure below 20%, then the burden isn't so bad. And I mean, in the UK, we buy some medicines over the counters. I mean, you don't necessarily want to get to zero, but you do not want to be up here. And we've got some big countries that we'll be hearing from India at the moment. India, Bangladesh, Pakistan, Cambodia, very, very low public spending, very high private spending, and you can see that these countries are a long way away from universal health coverage, and these are the ones that we deem as successes. And moving down here, as I say, is a very, very political process. It's exactly the same graph, but for Africa. And again, you can see some, sort of good performers down here, sort of South Africa, Namibia, Malawi, and these other countries not doing well at all. And the one I really want to say, Nigeria. Is anyone from Nigeria here? So we're having a meeting on Nigeria at Chatham House on Friday, actually, involving sort of politicians and people. For its income level, it's woeful. I mean, the $2,800 per capita country, and virtually all health services being bought by out-of-pocket expenditures. Sure.
So that's financing to
Exactly. Yeah.
That's
right. And I must say that both on this graph and the previous one, I think some of these figures are a bit suspect. I mean, I take this off the World Bank sites, which I think they get. I think, yeah. I know you said copy, yeah, that is good. Well spotted, yeah. No. In fact, yeah, I need to improve that graph. You get the idea.
I'm trying to highlight it now with this graph.
Moving swiftly on. Now, we have seen, both in the Asian context and in Africa, countries suddenly making quite big moves down this graph. And what you do tend to find is that it's not a sort of a gradual process. You get countries making sort of, quite big jumps. And I want to give you an example here in Sierra Leone. I took this photo Monday afternoon, and in this waiting room, in this small health centre just outside Freetown, you can see there are no people there at all. So in terms of it, providing universal health coverage, this facility is pretty useless at the time, unless you're trying to cover chickens. Now, 4 days later, it's 3 days later, it's full of pregnant women and children. This is the same waiting room. I couldn't take the photo from the same angle, unfortunately. Now, does anyone know why that happened? What happened in terms of any sort of universal health coverage reform to go from that to this so quickly? That's right. It's funny because I always put this in the presentation, and often people say, "Oh, did they recruit some new doctors, or did they get some medicine supply delivered?" People sort of thinking supply side. Quite simply, they scrapped user fees. They got rid of the user fees, and there was a surge in demand. And this is the photo trying to get into the children's hospital that day. It's quite astonishing, this surge in demand. And the point I want to make is that as this was happening, getting into children's hospital, just around the corner here at the maternity hospital, the president was announcing this new policy. Well, it was launching it. They'd already sort of built it, and this was the launch of the policy. And huge crowds of people there, people really sort of dancing in the street, really, that this move had been taken. And the point I want to make that this was Independence Day, led by the president. It was highly political. And its sort of genesis was partly because our Prime Minister, Gordon Brown, had been talking to the President about this and sort of suggesting that this might be something he wants to consider. So politicians talking to each other sort of created this. Now, obviously, with the Ebola epidemic that sort of followed, the fragile health system wasn't able to sort of cope with that epidemic. And, no one's suggesting for a moment this is a panacea, and there's still issues around the amount of financing that, the government's putting in. But this does show just how important it is to sort of get rid of the out-of-pocket payments. So why did the head of state do this? Well, why did he get engaged? And this is sort of very much now, the sort of latter part of the presentation, is explicitly to look at the politics of it and suggest that, I'd like to suggest to you that we should be getting much more active in trying to catalyse this. How can we get more people like the President of Sierra Leone to sort of make moves like this? So why might politicians be interested in this? Because really everyone on the planet wants universal health coverage. They want to get health services. They don't want to be impoverished as a result. It's also it's a policy, it's an issue that's very easy for people to understand and for politicians to relate to their populations. I've been in ministries of health in Indonesia where people are literally been demonstrating outside for it, shouting, we want, I don't think the words were exactly universal health coverage, but the banners were sort of saying, we want health services and we want you, the government, to pay for it. I think another reason that politicians like this, and it was absolutely obvious from the conversations with the President of Sierra Leone, is it brings quick wins. That you can go from a situation that has a pretty horrible health system to lots of people coming, getting services, getting medicines, and you can do this across the country very, very quickly. I mean, I took those photos in Freetown. I went on a little drive round. Every village we went to, you didn't have to ask, where's the health centre? You just saw the crowds. It was really quite astonishing. But because it is political, because it requires big increases in public financing, because it will be opposed by powerful vested interest groups, leadership from the head of state is essential. And there have been attempts to try things like this, led by, say, maybe a very charismatic Minister of Health, but it's failed because, the rest of the government haven't gone along with it, and the Ministry of Finance hasn't come up with the money. One thinks of the example of Kenya about 10 years ago, where charity and healing reforms, really because the president didn't get engaged. Now, someone who I think has really recognised all this and has quite explicitly said that he believes in universal health coverage and really wants to get involved in the politics of this is the new Director General of WHO, Tedros, and he's been sort of going around the world just in the last month, going to the regional committees in Africa and Asia and all over the place, raising this as an issue. And I think that this was a news report just last week from when he was in Africa. And I think that what we need to be doing is sort of helping political leaders and health people to promote this idea that it's a great thing for politicians to do this, because quite bluntly, not only might it help them win power, stay in power, it can turn them into national heroes. Politicians want to go into politics. I mean, they have huge egos, a lot of politicians. They want to feel that when they step down, they're going to go down in their history books, and it happens. Tommy Douglas from Canada was voted by the Canadian population about 10, 15 years ago the greatest Canadian ever. And because he brought, I think it was in the Michael Moore film, I think that he found that out. And Nye Bevan, the architect of the NHS, this is on the day of the launch of it's also that sort of biblical list, laying hands on this stuff, who's become famous in her own right, actually, as being, one of the first patients in the NHS. And, Nye Bevan is, super popular. And you know that we Brits, we love our NHS. I mean, it's I know we can be a bit evangelical about it. This was the Olympics. Do you remember it was hilarious that when it was the Olympics in London and the NHS area, I think it's got these beds, hospital beds, from Great Ormond Street, all these children dancing. And I saw some of the coverage in the US, and we didn't know this was happening. It was all a big surprise that we were so proud. But we've seen clips of the US people, NHS, what is that? So, people not really understanding it. But it's so politicized that this is happening in real time. This is now that we've had this Brexit debacle, and you've got buffoon of a foreign secretary we've got, like sort of trying to sell it to the population, saying, oh, we'll take our money back from Europe and we'll spend it on the NHS. I mean, it's an absolute lie, straight out of Trump's top drawer. This is how, these things pan out. But across the world, this is something that's happening. In Thailand, where the Prime Minister in 2002 launched universal health coverage reforms, the 30-baht scheme it was called, hugely popular, and he remains very popular with the rural poor in Thailand. And still a big figure in Thailand, living in exile at Indonesia. Now, I've got a few slides on Indonesia. In fact, I've got one of these cards here, I think. In Indonesia, the president, this was when Jokowi was governor of Jakarta. And within a month of becoming the governor, he was out handing out these cards, entitling people to free health services in Jakarta. It was wonderful because the previous government had been having this glacial approach to it and trying to cover the formal sector and very inequitable. But Jokowi just came straight in and provided these free health services. So that was sort of about October 2012. His popularity rocketed all over the country. And then just a couple of months or 3 months before the election, a survey conducted by the Jakarta Post was asking people, why do you like Jokowi so much? What's he done for you? And his health reforms, 57% of respondents said, his health reforms are fantastic. In a very difficult sort of dysfunctional city with terrible traffic and air pollution and lots of intractable problems are going to take decades to sort out. He knew that going for quick health reforms was going to be a smart move. And so therefore, in the presidential election, on television, he announced that he was going to extend this to the entire population, basically saying, what I've done for Jakarta, I am now going to do for the whole country. But unfortunately, he hasn't actually seen through on that promise yet, although we still think that that's his intention. There's still about 100 million in terms of not covered, and the step I would suggest that Indonesia needs to take is exactly what Thailand did 15 years ago or something, to make it a genuine universal entitlement. And this is former Secretary General of the United Nations talking to Jokowi about this, and off the record, that is exactly what that briefing is suggesting to him. It's a smart move for you to extend coverage to the entire population. So these are all things happening in real time. And South Africa is the country that really, for its income levels, should be doing a lot better. And it's got huge backlash from the private sector and private insurance companies. Got a wonderful Minister of Health who knows what he wants to do. The problem is the Treasury aren't really coming up with the money, and President Zuma isn't interested. And there's relations between the Minister of Health and the Prime Minister and the President aren't particularly good. So it's a problem, and without that leadership from the head of state, you feel it's going to struggle in South Africa. Now, the likelihood is that President Zuma is going to step down at the end of this year. So who's talking to the ANC leaders who are going to be fighting for the crown to say, top tip, if you want to win the trade union vote and make everyone happy, back Mozzarelli's UHC reforms. Nigeria, I've mentioned, there was a great sort of buzz of excitement at the election of President Buhari. Sadly, it's just not happened, and still, Nigeria is going nowhere on UHC. But at the state level, what you're finding is some state governors now are recognizing this is very popular and are beginning to increase their popularity by bringing reforms into their state, just like Jokowi did in Jakarta. I won't say much about India because Vikram's going to mention that fascinating in India at the moment, where the leader of the AAP party has introduced these things called Mahala clinics, universal free primary healthcare services, and in an overtly political challenge to the Modi government, It's saying we are going to, build up our power and popularity largely on the back of free health and education services and tackling corruption, and that they recognise this is something that they can have an impact very quickly. And one wonders, other countries as well. I mean, we're hearing terrible things out of Myanmar at the moment, and that things aren't going at all well. But sort of massive universal health coverage reforms be some type of mechanism that the NLD can sort of demonstrate that it really cares about all its citizens. And obviously that's not going to resolve that particular conflict in Rakhine. But you just feel that, that even in this very difficult political environment, that might be a smart thing to sell. And the United States, I think, now is the time, that we could perhaps discuss this. You're going to be the experts in this more than me. But that this was only last week, it's not the week before. That Bernie Sanders launching his Medicare for All plans, but very significantly, you can see people who are potentially going to also be vying to run for president now saying, we're going to go for it now. Let's stop messing about and let's go for that system. And I think that's fantastic. So how do we generate the political commitment? Because I'd say without it, without the head of state being behind it, you're going to really struggle. So what might we do? Well, I think that any of us involved in trying to encourage big UHC reforms, general health reforms, is involve politicians right from the outset. Don't sort of do something very technical and then try and go to finance and just get knocked back and be told that the Treasury can't fund it, and then at the last minute try and engage the politicians. You want the head of state to be driving the whole thing. And then, involve all the interests of, civil society organisations, trade unions, the media. You really want to politicise it. I know there's often a tendency, those from a health background to think, oh, this is rather inexact science, this, and we're going to have to get involved in the dark arts of public relations. And, it's, no. But really, we just got to do it. And be thinking about tailoring our messages for different audiences. So, trying to sell to the economic benefits to finance people. But in particular, sell the political benefits. We're so reticent to do this. I think this is our greatest failure, that recognizing that our best sell to a politician is, this rather brutal idea that if you do this, you are going to become popular, you are going to get votes, and you will get power. Link the health reforms to them getting power, because that's what they want. So, right through government needs to be promoting the political benefits to the head of state. Also, and this is where we perhaps need to be a bit smart, think of how can we link these UHC reforms to other things the government might be trying to do? Because, what we're really saying here is that if you do this, you're going to generate tons of political capital. You're going to be really popular. This is going to look good. But your government is trying to do some things that are unpopular, people that don't want to do, that you're struggling to get through, and when you try, there are demonstrations. I've used the example here of cutting fuel subsidies. There are lots of governments have got into this mess of subsidising fossil fuels. They want to get out of it. So if we can say link our popular health reform, so why don't you do that at the same time as you cut fuel subsidies, or increase subsidies on fuels, or introduce new taxes? And this is what Indonesia is doing. This is what Jokowi is doing. Iran's doing it as well. They have explicitly launched popular health reforms whilst cutting fuel subsidies and saying to the population, you're going to pay more for your gas, but you're going to get free healthcare now. And be really smart to think, with timing, when should we be selling this, coming up for, Kenya's got presidential elections coming up in a month or two now, a rerun of the previous, again, but you feel that particularly the opposition party, that they need to pull a rabbit out of a hat, to have a rerun of the previous campaign. So, might this be the time that they campaign on a publicly financed UHC ticket? Watch this space on that one. I'm rather embarrassed to put the slide up, actually. So I'm just trying to explain here what we at Chatham House are trying to do, that we are trying to do this type of work. You know, we are trying to sell the political benefits of UHC reforms, actually get involved in the politics rather than analysing it. So these are just one or two examples. This is I'm at a conference in Nigeria, and this is the governor of Ondo State, who's introduced universal free health services for pregnant women and children. He's the chair of the governors from the opposition party, and it's pretty obvious that, you know, he's got aspirations for higher office. You know, we're sort of encouraging him to run on that platform. This is yours truly with Jokowi while he was governor of Jakarta, just before he started his presidential campaign. And you know, I'd love to claim it was my idea that he ran on this, but he was going to do it anyway. But it was very interesting that in sort of talking to him about the figures and the numbers, I think we were able to give him confidence to do it. And he'd got no idea that this had been done in other countries. You know, he found this absolutely fascinating. This is the Elders Foundation, who now have this big program on universal health coverage, and they are looking for opportunities to. I mean, you've got Kofi now, as I mentioned, was talking to Jokowi quite recently about this. Interestingly as well, and again, this is very much off the record, they're beginning to wonder now about dipping their toes into the US environment and whether, you know, some engagement from the elders might just help move things on a bit. They're interested in your views on that. And I'd say Tedros is really up for this now, and in our discussions is saying, where can we see these opportunities opening up, and how can we work with the whole global health community and academics, you know, to move this agenda on. So last slide. What I'm trying to get across here is that, I've got the whole point. I put that previous slide up. The problem is that in doing this work, we haven't got any money. You know, Chatham House, we're running on sort of complete shoestring, and we're struggling to find donors who are prepared to sort of support this type of stuff. I think people are nervous about the politics. We're getting a little bit from OSF, but if you can sort of think of any sort of great philanthropists who might want to do some of this, you might say sort of rather high risk, you know, work, then I would love to hear your thoughts on this. I saw it was one of the objectives of today was to talk about funding, so that's why I just put that slide in. Anyway, the argument UHC is mostly political, I'd say. You know, that we know what interventions work, we know how to finance it really. Making it happen is hugely political, especially in revising the financing. It's universally popular, you know, with people all across the world. You know, it's an easy thing to understand. And I'd say what's interesting about the concept, it brings politics explicitly into these discussions about health systems. Health systems are vital, of course, we all know that, but to be perfectly frank, in having tried to sell health systems agenda to former Labour Secretaries of State in the UK, it's boring. You know, it's boring. You know, you try and you talk to politicians about health systems, and oh God, you know, and it's just always helped people wanting more resources for themselves. You talk about people being covered, everyone getting health services, you know, they just understand it much more. So it's just words really, but it makes all the difference. Across the world, it really is politicians who are driving this, and so therefore we really should be targeting them. And you know, I think that collectively we need to be raising our game and engaging in this. You know, that for far too often, the moment it gets political, we dive under the table. And it's like, oh no, we just can't deal with it. But if we're going to get UHC, then I think we need to get smarter at engaging in the political economy.